Very good morning to all. Good afternoon, rather, to all. And I'd like to thank Dr. Shubhendu for providing me with the opportunity here this afternoon. I'll be speaking on changing concepts to intervene in diabetics. So, what's new today? I have no financial interest. Well, let's go back and look what initially happened was that Makima's prototype detector was a 14-gauge instrument, and gradually people moved on to 20 gauge. Initially the commercially available vitrectomy probes were around 19 gauge. So it was a story that began with 19 gauge, moved on to 20 gauge, and during those times the indication for diabetic vitrectomy in the early days was non-clearing vitreous hemorrhage. Non-clearing is an important word here. Why? Because the wait was long, 3 to 6 months. But then time moved on, and winds of change started blowing with advancing surgical instrumentation and technology. Indications for vitrectomy in diabetic retinopathy have expanded. Today you have a whole gamut of indications, and this is primarily because better surgical control, better understanding of the disease, you feel more confident to deliver results in many more patients. So that's why the change has come about. Now, it has become possible because of, firstly, improved diagnostics. What are the basic sort of a proliferative diabetic retinopathy? You would think you would laser it off and that's it. Patient would stay at maybe 636 or whatever. With OCT coming in, what we saw was, well, there was something additional to what was seen on angiograms. So you had these ERMs here, traction here, and that was the reason of the macular edema not going away. So what you did surgery for this, and you gave the patient something like this, so that the vision also improved, the anatomy was also restored. It was possible because we moved on from Landers and Makimer's irrigating lenses to wide-angled, wide-field lenses, which gave a better idea of the retina. You could do better laser, you could do sort of better vitrectomy, more efficient membrane peeling. I'll just be sort of covering the topics because all of these will be covered later on by the other speakers. So this is how the wide angle viewing changed. Now we moved on from 20 gauge to 23 gauge and 25 gauge now, to some extent 27 gauge also. And how this change was that instead of using this 20 gauge MVR, we moved on to these stroker cannula based systems, either 23 or 25 or 27. Now how this affected the patient was that it had multiple benefits. Firstly, there was lesser scarring. You had these patients with some of whom you needed multiple vitrectomies, so you could go in once again. You were not scared of the conjunctiva and the sclera, becoming necrosed and all that. Then you also had those patients in diabetics who would need a trabeculectomy at some point of time. And I remember my glaucoma friends telling me, hey, conjunctiva bacha ke rakhna yaar. So that is something that's a thing of the past, because the trocar cannula based systems, you have lesser amount of scarring, and for the patient also it's difference between this and this, a more sort of normal looking eye and lesser amount of inflammation. The patient is also happy. Now previously, with the previous generation machines, you could set your VGFI levels at maybe 35 or 40 or whatever, but then when you had the cutter working or maybe your flute needle or whatever inside the eye, it was a dynamic thing that happened, and then at that point of time you did not have any control on the IOP. So what happened was, the new concept in infusion fluidics was that you have to have a IOP that is sustainable inside the eye, that is at a stable level inside the eye. And how it helped was that you could work at lower pressures, and that was important because in these diabetics you have an sort of an ischemic optic nerve, which it becomes further compromised if you have a very raised intraocular pressure, if you work with a very too much raised intraocular pressure. So next, this is the kind of diabetics you operated on until a few years back, but then with preoperative bevacizumab the scenario changed. This florid vascularization became less aggressive, and you could operate these kind of cases more easily. Next, vitreous, as we all know, is something that's little difficult to visualize, and so also sometimes the membranes and all. Now how things have changed is that today we have systems wherein you could visualize the vitreous and the membranes more easily. So you could delineate the vitreous with triamcinolone acetonide, and you can also sort of delineate the membranes, epiretinal membranes. If you want to remove the ILM and all, you have BBG going for you and doing the job of, at least you have better visualization. So when you can visualize things better, you can also do a better job as far as the surgery is concerned. It's become possible ultimately because of better understanding of the disease process. So certain times we go in early, where especially when no previous laser treatment has been done, extensive fibrovascular patients with extensive fibrovascular proliferation, where fellow eye has a history of rapidly progressive visual loss, or when the fellow eye is blind. These are situations you really need to do it fast. Next, there are situations when you have a patient like this. Even though the hemorrhage may clear in a few months' time, but there is always an ongoing fibrovascular proliferation that frequently establishes a broad-based traction, and ultimately what happens is there are tight vitreoretinal adhesions, there is a combined RD-like situation, and these patients really do well if you wait until this stage to operate. The confinement of blood in the subhyaloid space indicates that the posterior hyaloid has not been fully separated. So this is very important and remains as a scaffold for the progressive fibrovascular proliferation, which sets in a few weeks' time. Next, this is the stage, for example, where one needs to operate, and rather than wait till it's a florid kind of a thing and combined retinal detachment has set in. So this is what has changed. Now let's look at something as mundane as DME. What does the DRCR net results show? Well, 38%, almost 40% patients showed a 10-letter improvement with vitrectomy. This is important. What is, of course, also important is that who needs to be operated. That's something that you need to look into. And another thing, whether the traction is causing the diabetic macular edema to persist. So if you have something like this, you need to go in, cut this off, and settle, the patient settles with something like this, and the patient's vision also improves, the edema goes down. Now, you do more vitrectomies, you have developed more cataracts. That's the saying. So this is something you have to expect. Of course, with vitrectomy, the number of cataracts are going up. But what has changed is that today you need not be scared of doing cataracts, because it has come out in peer-reviewed journals a long time back that 15% patients after diabetic vitrectomy tend to develop cataract. Early chance of developing a cataract, as opposed to 66% after macular hole surgery and 53% after ERM. So, don't be scared of doing your diabetics a little early. Now, what actually has changed in this segment or, doing cataracts is that today we are using machines which have a very good phaco machine incorporated into the vitrectomy machine. So, you don't need to pull your cataract surgeon's infinity or whatever to do your cataracts. Today's new generation vitrectomy machines are equipped with phaco machines which are capable of dealing with the hardest of cataracts. And I, for one, for the last 2 years, I haven't, sort of almost 1.5 to 2 years, I haven't brought in an Infinity or some other machine to do my cataracts. So you have to do, of course, a few combined surgeries also in your OTs. So these are manageable with the new generation machines. So this is what has changed. So basically, evolution of surgical indications, evolution of vitrectomy machines, and evolution of our surgical techniques has made the winds of change possible. Thank you for your kind attention.
Thank you, Debdulal, for your nice presentation.